Welcome back, everyone. I hope you had a refreshing break. We will now proceed with the second half of our day. We will begin with Justine Moonen, who is a postdoc at the Alzheimer Center Amsterdam, one of the most important centers of Europe. She plays a key role in the Netherlands Consortium of Dementia Cohorts, aiming to prevent vascular dementia. With a background in research at the National Institute of Aging, Dr. Moonen's work focuses on how MRI features link to small vessel disease and amyloid-beta, affecting cognitive decline and dementia progression. In her talk, she will reveal the complexities of the most common type of cognitive decline. We are very grateful that you could attend the conference, and we hope to gain a lot of knowledge from your observations. Welcome.
Yeah, thank you so much for this kind introduction. I'm very honored to be invited to speak here at Neurocon. Can you see my screen?
Yes.
Perfect. All right, so my talk is on biomarkers for vascular and Alzheimer's dementia. Let me see if I can. Oh, yeah. So here are my disclosures. Just gonna move. All right, so my work is funded by ZonMW, a Dutch funding organization for research in Alzheimer, Netherlands. The outline of my presentation is on AD and vascular cognitive impairment. And for both, I will go into the risk factors, mainly about the focus will be on the biomarkers for both clinical decline, briefly on therapy and prevention. And I also want to focus on the contribution of both AD and VCI biomarkers combined and how they contribute to clinical decline. I first want to make the statement that mixed pathology is very common in dementia. So dementia is an umbrella term, with AD being the most prevalent type of dementia, vascular the second most common type. But in up to 30 to 40% of late onset dementia, there's a combination of both AD pathology and vascular pathology. Now I want to jump back to AD only for the next few slides. So AD is highly dependent on heritable factors, about 60 to 80%. What's very rare are the causal genes. So this is very rare. Then you have autosomal dominant Alzheimer's disease, which has an early onset as well. Those are the rare causal genes. What's more common are risk increasing genetic variants, of which ApoE4 is the most well-known risk allele, and also gives quite a large, 3 to 4 times increased risk of AD. There was a statement paper in Lancet that also identified modifiable or pointed out modifiable factors for AD that included, for example, smoking, high blood pressure, so stop smoking, lowering hypertension, or having a higher level, increasing your education could prevent dementia. So now back to the biomarkers for AD pathology. Key hallmarks for AD are amyloid-beta plaques that can accumulate between the neurons. Tau tangles, also a protein, pathological protein of AD, which in the end can lead to neurodegeneration, so loss of brain volume. And as you can see here with the years, before you get demented, there's a very long preclinical and pre-morbid phase of accumulating damage. So you first have you can still have normal cognition and already have the first signs of pathological signs of AD. And then with the pathology building up, you can go from MCI to, in the end, to dementia. So there's a long preclinical phase, a long disease process. And this is, so what you see here is a PET scan. On the bottom, you can see the estimated years to onset of dementia, counting down, so 20 years prior. And you can already see the brain getting more red, indicating amyloid-beta buildup in various locations of the brain. So this is quite impressive, and actually the rate of accumulation slows down a bit once you are demented, because the color indicates accumulation per year. But this again shows you that amyloid-beta, the protein, the AD protein, has a long build-up time. All right, so the core biomarkers for AD, as I've just highlighted, are amyloid-beta and tau proteins. You can visualize them on PET imaging, which you've just seen. That's an imaging biomarker. But you can also measure them in cerebrospinal fluid, which you can measure with a lumbar puncture to acquire CSF, cerebrospinal fluid. The newest biomarkers, it's not yet implemented in clinic, but this is a very promising development, that you can measure these proteins in the blood-based biomarkers. A lot of research is being done because the newest sensitive assays allow quantification of these proteins in blood in very low concentrations. So that's a promising development because it's less expensive and, of course, less invasive than PET or lumbar puncture, and a much more accessible method. So these were the core biomarkers. Now the other biomarkers for AD. Neurodegeneration, loss of brain volume, is also a key imaging factor of AD, and you can visualize it on MRI. MRI can also be used to quantify vascular co-pathologies. I will come back to that later on. So with the lumbar puncture, you can not only quantify the amyloid-beta and the tau, the AD hallmarks, but you can also measure, for example, NFL, that's neurofilament light, which is an aspecific fluid biomarker for neurodegeneration. It can also be increased in various other neurodegenerative diseases. Briefly, want to state that GFAP, that's a marker for inflammation, which can also be, which is increased in the preclinical phase of AD and one's having AD, and you can both measure NFL and GFAP both in the blood and in the CSF. So those are markers for AD, but are aspecific, also increased in other diseases. I would really advise you to look into these novel revised criteria for AD of the National Institute on Aging. It's still a draft, so it's open for public comments, but they have, revised the criteria for diagnosis and staging. So again, they say AD is not a clinical syndrome; it's biologically defined, and it's defined by presence of these core biomarkers, the core AD biomarkers, amyloid-beta or tau. And then they have this overview in the paper on the right-hand side. You can see it. They split it up in presence of core biomarkers, in non-specific biomarkers that are involved in AD, but can also be present in other diseases, including the neurodegeneration, which I've just mentioned. Another one is inflammation. I won't go into that much during this talk, but you can measure inflammatory markers as well in, not in imaging, by the way, sorry, in CSF and plasma. Then there are biomarkers of non-AD co-pathology. As I mentioned, the vascular pathology is very common. It's a very common co-occurring pathology, and you can measure that on MRI. So this paper gives, of this draft of these revised criteria, give a nice, a nice overview, a nice classification. That gives a good overview of the diagnostic criteria. So then a bit about the sequence of the biomarkers. So in this figure on the y-axis, you see level of biomarker abnormalities. So higher will say you have more pathology of a particular marker, and on the x-axis is time. And as you can see here, the first one in the pathological, during the pathological timeline is amyloid-beta. Then next, that may drive tau accumulation in the brain. That's the blue line. Mostly first in the medial temporal lobe and then neocortical. And then at a later stage, once you have all these pathological proteins in your brain, then you can get loss of brain volume and cell death. So that's at a later stage, the pink line. And then at some time you can get clinical symptoms. This figure visualizes, so what happens with these timelines if you have co-pathology, if you have vascular co-pathologies, then you can actually get a shift. So then at a fairly low level, for example, of amyloid, for example, if you are here, you can already get loss of brain volume and already clinical symptoms while there's less, for example, tau. And that can be caused by, hey, there's a lot of co-pathology, there's vascular co-pathology, so you can already get clinical symptoms and loss of brain volume that does not immediately match the tau level, for example, because so then you get a leftward shift of clinical symptoms. Vascular co-pathology. All right, so there's a lot of lines here, but I walk you through. This is a very interesting study in about 700 persons that were still at subjective cognitive decline, so no objectifiable cognitive decline of about 60 years. And on the y-axis, you can see dementia-free survival. So this brownish line, for example, that has the highest dementia, increased risk of dementia, because they get the most dementia. Here is the group with, it makes sense in a way. Hey, you have both amyloid and you have tau and you have neurodegeneration. Well, then you are at the highest increased risk of getting dementia. That's this line. But what it shows, it indeed is that A+ groups are at increased dementia risk, and the risk was further increased when additionally you have either a T+, the tau, and or the neurodegeneration. And this group is also at increased risk, which is non-AD pathology, actually. So more biomarkers that are positive, a larger increased dementia risk. Briefly want to state the AD drugs. So far there's, the last years it was only symptomatic treatment with the cholinesterase inhibitors and memantine, which had limited minimal effects on functional abilities and cognitive performance. But what is novel, I don't know if it's been mentioned on this conference before, but the first disease-modifying treatment have been out there on the market in the US. That's aducanumab and lecanemab. And these are anti-amyloid monoclonal antibodies. So they target the amyloid-beta protein. They clear up the PET scans. And they also have shown to slow clinical decline. So these trials show that the treatment group had less cognitive decline than the control group. It was a limited effect, so a small clinical benefit. And what also should be mentioned briefly here is that there are significant side effects of these treatments. They are called amyloid-related imaging abnormality, ARIA. You can get edema or hematoma as side effects of these treatments. So I think it's a big scientific breakthrough. The first disease-modifying therapies are out there, but there's still quite some controversy because you get the side effects and limited clinical benefits, but nevertheless promising scientific developments. Let me see how I am with time. Okay, so this is donanemab. This is not yet FDA approved in the US, but it's also a trial showing, can go to the conclusion at the top here, that among patients with early symptomatic AD, and they were also positive for amyloid and tau, so they had biologically defined AD, but still in an early stage, this drug, donanemab, significantly slowed clinical progression at 67 weeks, in low to medium tau group and the combined low to medium tau pathology population. They did some stratified analysis. So they all show, this is donanemab, so it's the same group as aducanumab and lecanemab. They're all anti-amyloid monoclonal antibodies. So again, this one showed less clinical decline in the treatment group. So far about AD. Now I want to go into the vascular cognitive impairment. And vascular cognitive impairment vascular relates to blood vessels in the brain. And it refers to, it's quite broad. So VCI refers to all the way, again, from subjective cognitive decline, so to MCI, mild cognitive impairment, to vascular dementia. So it's any cognitive decline relating to vascular damage in the brain. This is the, there's also a classification consensus paper, and that's defined that you can have mild VCI, then you have no disruption of instrumental activities of daily living, you're still functioning quite well, or you have major VCI is also known as the vascular dementia, and then criterion is that you have severe disruption of your daily life functioning. So you have cognitive deficits, and there's neuroimaging evidence, neuroimaging evidence for vascular damage on the MRI. And we're going to look at several MRI images later on. So how does this look on MRI? I'm going to show you. First, a bit about the risk factors for VCI. You may recognize several of these risk factors because all the risk factors for VCI show a very strong overlap, of course, to risk factors for other major vascular conditions, such as heart diseases. So everything that's hypertension, a high blood pressure is a very well-known risk factor also for VCI. So a high blood pressure, it's bad for the vessels and it can lead to vascular damage in the brain. The same is true for diabetes, high cholesterol, obesity, but of course there's a close heart-brain connection. So also heart failure is a risk factor for VCI because it can lead to cerebral hyperperfusion, less flow in the brain, and atrial fibrillation as well. If you have atrial fibrillation, arrhythmia in the heart, it can shoot emboli into the brain as well. So these are cardiovascular risk factors. There's also lifestyle factors increasing the risk of VCI: smoking, poor diet, low exercise, high alcohol, and luckily some protective factors. And higher education is a protective factor, and remaining cognitively and socially active. There's some non-modifiable risk factors for VCI. Of course, increasing age, higher age is a major risk factor for VCI, and there's a rare genetic form of VCI, the Notch3 gene, for CADASIL. And ApoE4, this is the risk gene I mentioned for AD before. It may also play a role in VCI, risk increasing gene. So now a bit more about VCI. What underlies VCI? You can have damage to larger vessels or to smaller vessels in the brain. Larger vessels, of course, if you get a major stroke, a stroke can either be ischemic, a lack of oxygen due to a blockage of a blood clot. You can see it here, a blockage of a major artery, or it can be hemorrhagic, a bleeding, a bloody stroke, which can lead to major damage in the brain and increases your risk of dementia. Another form of larger and also medium-sized vessels are multi-infarct dementias. You get several tiny strokes, ischemic strokes, which can lead to VCI. The most common form actually is damage to the smaller vessels in the brain. The most common cause of VCI is due to small vessel disease, the small penetrating vessels into the deeper areas of the brain. So again, the post-stroke dementia, ischemic or hemorrhagic, which I've just mentioned. And you can imagine that the clinical decline, if you first, you have you function well, you have a normal level of cognitive function, you get a major stroke, and then within 6 months you can become, that's the criterion that you can get dementia very quickly. It's acute, large damage, And this is your huge decline in dementia. This is an image of a major ischemic stroke. This is multi-infarct dementia. On the brain image, you can see all the white dots on the scan are tiny ischemic lesions, lack of oxygen. So, and then you can imagine that's a stepwise decline. Each time you get a new infarction, tiny infarction, you decline a bit more. Now the small vessels, that's actually a very gradual, slow decline over time. And these are three manifestations, MRI manifestations of small vessel disease. The white matter hyperintensities, you can see them here around the ventricles. The lacunes, infarction there, or tiny microbleeds, the black dots here on this T2 star sequence. So the white matter hyperintensities is the most studied small vessel disease biomarker of VCI. You can visualize it on FLAIR imaging, which you can see here. And it's defined as a signal abnormality of variable size in the white matter. And this is increasing severity. So this is a visual rating scale, the Vascular scale. Oh, we have a question. I'm not sure. Do you do questions live on the? I see a question.
We're usually leaving them for after the talk, but if you want, we can see them now.
Yeah, sure. I think Bianca Wiersma has a question. Or did you put your hand up not on purpose? If not, maybe there's just an accidental hand. There's just an accident. Okay, I'll just go on, I think. All right.
Okay.
It's mostly symmetrical. So here you can see the increasing severity on the Vascular's visual rating scale with the most severe white matter hyperintensities with large confluent white matter hyperintense lesions. Then the lacune, another MRI biomarker of small vessel disease, again visualized on FLAIR. It's subcortical, so it's below the cortex in the deeper brain areas. It's a fluid-filled round cavity, so actually just a tiny hole in the brain, more or less, and it can result from acute small subcortical infarct or hemorrhage of one perforating arteriole. So the vessel goes like this, gets occluded, and then you get an infarction there. Then the microbleeds, another MRI marker of small vessel disease. They're micro, so only up to a max of 10 millimeter in size, small bleeds in the brain. You can visualize them on T2 star imaging. And either be lobar, this is a brain with many lobar microbleeds, or deeper in the brain, deeper brain areas, the basal ganglia and the thalamus or the brainstem. And if you have mostly lobar only microbleeds, that's related to cerebral amyloid angiopathy. That's amyloid buildup in the vessel wall of in the cortex, which can lead to lobar microbleeds related to CAA, while the deeper microbleeds are more related to hypertension. So this is a recent paper of Lancet Neurology of in this year, 2023, and they also updated the neuroimaging standards for research into small vessel disease, the STRIVE-2 position paper. And in this paper, they highlight several things. So what I've just mentioned, the core small vessel disease biomarkers, the lacunes I've showed you the white matter hyperintensities, and I've showed you the cerebral microbleeds. But there are several emerging SVD biomarkers, and in STRIVE-2, they underline the need to look more broadly. So what you have, you can also get, for example, cortical superficial siderosis, which is hemosiderin buildup, so blood products build up along the sulci here, which is also related to CAA and can be accompanied by microbleeds. The enlarged perivascular spaces, you can see them here, the white areas. So that's more fluid buildup around the vessels, leakage and drainage issues. And recent small subcortical infarct. So these can actually progress into a lagoon if you wait longer. But I think the takeaway from this is strive to underlines the need to look at novel emerging small vessel disease markers other than the ones that have been studied for a prolonged period of time. So look into this paper, it gives a nice overview. What else they stress, I've showed you several visual rating skills, visual rating for the biomarker white matter hyperintensities. What's most often done now as well is the counting of the lagoons and the counting of microbeads. But of course, with all the new, you have automated assessments with very new pre-processing pipelines, and then you can get not only visual rating skills, but you can get automated computational milliliters, for example. They can be very specific, and you have so many milliliters white matter hyperintensities. So use those advanced automated assessments of volumes, for example, and also other sequences, which are listed here, which can measure other functional and structural vascular damage. So ASL, arterial spin labeling, can measure the perfusion in the brain. Often in small vessel disease, you have a lower cerebral perfusion, and you can just measure the cerebral perfusion with ASL, with arterial spin labeling. In small vessel disease, you can also have blood-brain barrier dysfunction. So that's on a really tiny level. You cannot visualize the blood-brain barrier with T3 MRI. You need different sequence with permeability imaging. And DTI, it's already out there for quite a while as well, but it's diffusion tensor imaging, which can visualize the white matter microstructure. All right, so this paper gives a nice overview of all the vascular biomarkers, small vessel disease MRI features. So if you have these small vessel disease features, does it actually predict dementia? Well, the answer is yes. This is data from the Rotterdam study in a large sample of over 1,600 persons, 73 years old. And it's quite difficult to research, you can imagine, because there's so many biomarkers. What they did is select key small vessel disease biomarkers, the white matter hyperintensities, the microbleeds, the lagoons, and the enlarged perivascular spaces. And they assigned a score if you have them if they are present or are at, even more than 11 perivascular spaces. If you have more, they made a compound score, and you can see that if you have this compound score of small vessel disease, predicted incident dementia. So more of these small vessel disease biomarkers in your brain on MRI is predictive of dementia. I'm just going to look. Okay, I have 15 minutes. All right, so treatment VCI, there's no disease-modifying treatments yet available. Once there is this vascular damage in the brain, you cannot cure it somehow. The damage is there. So it's key to prevent the vascular damage. So how do you prevent it? Healthy lifestyle. Keep your vessels healthy. So you should stop smoking. Smoking is bad for the vessels, as many of you may know. Get active. Control your cholesterol. The blood pressure shouldn't be too high. A healthy diet. Lose weight and reduce the blood sugar. So these are lifestyle measures to prevent VCI. All right, and now to the third part of my presentation, and I want to go into if you have both. I told you about AD, I've informed you about VCI, and now what happens if you have both pathologies at the same time, because that's quite prevalent. And why is it so prevalent? Well, actually, the small vessel disease features is very prevalent at old age, and it's not always leading to clinical symptoms. So you can see here, for example, these. Now let's do the microbleeds. The blue bar is for 60 to 69-year-olds, about 15%. But people over 80 years have up to 40% of microbleeds. So the older you get, the more vascular damage buildups in the brain, and it's very prevalent. So you can imagine that also in AD, it's a very common co-pathology. I want to show you some of the work that I've done to investigate the presence of both pathology and how they both then predict cognitive decline, dementia, and also mortality. And so far, most studies have investigated either the predictive value of small vessel disease, they focus on the SVD part, or you have more AD focused papers that look into the predictive value of AD markers of amyloid-beta and or tau. So limited study combine it. And that's also because you can imagine that there's limited data out there because amyloid-beta is mostly only measured in certain memory clinics where you have a PET scan or you have more the invasive lumbar puncture. So this is the question I wanted to answer. What if you have both pathologies in early stage, so still in non-demented persons? And how does each pathology predict cognitive decline, dementia, mortality? So either separate or combined pathologies. And I investigated this by looking into data of 3 cohorts: the Amsterdam dementia cohort, memory clinic cohort with about 450 of subjective cognitive decline or mild cognitive impairment. And then I've also included 2 population-based cohorts with normal cognitive function. And this was just how can I operationalize, how can you analyze all these various small vessel disease features from a pragmatic point of view, and also looking at the availability of the data. This is what we decided upon. We made a compound score. You could 1 point if you had presence of a lagoon or more. You could get 1 point if you have 1 or more microbleeds, and you could get 1 point if you have white matter hyperintensities on a Vaseka score of 2 or more. And then you were classified as vascular positive. So if you have either one of these 3, you were vascular positive. You had some vascular damage in the brain. Amyloid positivity was defined based on either the lumbar puncture or PET, so positive amyloid PET, or the lumbar puncture, and each cohort actually used different assays, different lab tests. You can see the cutoffs here for amyloid-beta 42. Some used a ratio of 42/40. So classification as amyloid positive. All right. Then a bit more about the cohorts themselves. Well, the 90 plus, this is of course, yeah, the 90 plus population, of course, is the oldest. The memory clinic patients were fairly young, which is also inherent to this memory clinic population, tertiary memory clinic. This is the MMZ score at baseline and the follow-up time of about 2 up to 3.5 years. This is interesting. So the amyloid positivity or vascular positivity, the amyloid positivity was highest in the MCI group, in the memory clinic patients, which is what you would expect. These patients have clinical symptoms, and they present themselves at a memory clinic population clinic. The vascular damage was by far highest in those with 90 plus, which is also what you would expect because it increased, the prevalence is strongly dependent on age. The damage builds up over time with age. Then we made 4 groups. So either you have no biomarkers, you're negative for both biomarkers, you only have vascular pathology, you only have amyloid, it's about 23%, or you have both pathologies, 17%. And then I ran the mixed models. This figure shows on the y-axis the MMSE score, so a global cognitive score. Age, sex, and education were included as fixed covariates, and the study sample as well. This is a pooled analysis. And what you can see here is that the reference group was those with no pathologies. Is that the largest effect estimates were found in the A+ groups. And this was a bit, that's what we expected, but we've also expected that this group would show the largest decline, right? If you have both pathologies, I felt like you would decline more, but that's not what we found. So it's just A+, you decline, but the V+, if you are A+, V+, it doesn't add a lot to, you do not show accelerated decline versus the other, the A+ V- group. Similar results were found for other cognitive domains. I'm not going to show you due to time, but we had very much cognitive tests, various cognitive domains, memory, attention, executive function. They showed a similar pattern. So now for progression to dementia, this is Cox regression. Again, the reference group is those with no pathologies. These are the hazard ratios, and you can see that the A+ groups, it's quite a difference. They do have a substantially larger hazard ratio than the A- groups. So A+ is highly predictive. Having amyloid is highly predictive of becoming demented. That's significant. And what we do see here as well is that those with no amyloids, but with small vessel disease pathology, the green line also shows an increased dementia risk with a hazard ratio of 1.8. So it is significant as well. But amyloid is the major key player in this sample, or the key predictor. The same is a bit true for mortality. So if you are A+, bottom two groups, you show a significant hazard ratio, a significantly increased hazard of mortality and that's both significant. So this particular study showed that in non-demented persons, amyloid-beta was strongly predictive of cognitive decline, dementia, and mortality. Small vessel disease modestly predicted dementia in those without amyloid, but surprisingly, it did not increase additional deleterious effects in A+ on cognition, dementia, and mortality. So I think these results underline the need to assess amyloid-beta in clinical practice, even when MRI findings indicate a diagnosis of VCI, because you see that if you also have amyloid, then you have a much more adverse clinical progress. I do want to give mention here that this is mainly driven, these results are mainly driven by a memory clinic population, right? Because the largest sample size came from a memory clinic population, so you cannot extrapolate or generalize these results one-on-one to more population-based or to the general population, because they were only a smaller part of my sample. So that's important for interpreting these findings. It's mostly memory clinic based, where A+ plays the major predictive role. So then I go to the overall take-home message of the entire presentation, that mixed dementia with both AD and vascular pathology are common in old age. It's often mixed pathologies. The first disease-modifying treatments are available for AD, which I've showed you, but they have small clinical benefits and side effects. So prevention remains key for now for AD and VCI, and that both biomarkers for AD and VCI are instrumental in predicting clinical decline. All right, so that was the presentation.
Thank you, Justine.
Oh.
Thank you very much for this informative presentation. We do have a few questions from the audience. The first one is from Lorena. She says, hello and thank you, Justine. Could the new plasma test for amyloid and tau biomarkers be implemented as a standard, also free procedure in the health system, so people could find out sooner if they suffer from AD? If yes, in which way would it impact the number of patients suffering from Alzheimer's manifesting symptoms of dementia?
Yes, thank you, Lorena. That's a great question. Within my clinic, they actually, it's under investigation. So yes, you could do it. You could implement it as a screening test, for example, within the first line. For example, if a patient presents itself at the GP with memory issues, you can do a brief screening test and also immediately draw blood and see like, hey, you have amyloid-beta and tau. Use it as a screening test, and then if they are positive, you can refer them to a memory clinic. So yes, it has great potential as a screening tool. There is also in the field some resistance to use it as a screening tool, because they say like, okay, we're going to screen all these people. There's such a long preclinical phase. Maybe it will take another 15 to 20 years until they get AD. We're going to worry these people, for example, and they may not even get it because they may die sooner of another disease. So there are, it's a tough topic. There are also patients saying like, yes, of course I would want to know, because then I can prepare, I can adjust my lifestyle, I can keep track of my cognition. So it's a field in development. It shows great promise, but there are several pros and cons in implementing in the first line. And it would affect, I think, earlier referral. And with these disease-modifying treatment in development could also lead to, selecting patients for future treatments. Yeah.
Okay, thank you. The next question is from Catalina. Hello, Justine, your presentation was really interesting. My question is, how might the field of precision medicine play a role in tailoring treatment approaches for individuals with mixed dementia based on their specific pathology and genetic factors?
Precision management, yeah, so if you have both pathologies, I'm thinking now that for the VCI, there's no disease-modifying treatment yet. But if you have both pathologies, the precision medicine, for example, now with the new disease-modifying treatments for AD, which also show side effects, the ARIA-E and the ARIA-H, the hemorrhage, and the edema. I can imagine that maybe potentially certain patients that show a high load of microbleeds, maybe, or like at increased risk of bleeding, may not be potentially eligible for some AD treatments. So I think because the mixed pathology is quite common, and also because the new AD drugs show vascular side effects, that it can be to really quantify both the AD pathology and the vascular pathology is not only valuable for prediction of clinical decline, but may also be useful for selecting of patients for certain AD drugs and or other treatments. So for eligibility of treatments, it can also play a role. Yeah.
Thank you. Another question from Tasia. Hello, Justine. Thank you for your wonderful presentation. I'm wondering, with the new knowledge of mixed dementia, how does this change the approach taken for implementing treatments? Would introducing a comprehensive treatment for mixed dementia is more effective than trying to tackle each specific pathology by steps?
Thank you, Tasha, for your question. Let me see the new, oh, don't delete it. Yeah. And the question's gone. No, it's okay. No, okay. So I think you're specifically asking for a comprehensive treatment. I do think the future will probably be that there will be multiple treatments targeting the various pathologies. So I don't think there will be one drug. I rather think it will be multiple. So for hopefully that you have those monoclonal antibodies targeting amyloid-beta for the AD pathologies, and that you maybe have hopefully another, I think, another future drug targeting particular vascular functions in the brain, maybe to so far there's not a disease-modifying treatment, but I can imagine that in the future there may be certain treatments targeting vascular processes. So I rather think it will be a multi-targeted therapies because it's so multi-causal. The mixed pathologies all have their own risk factors and have their own so it will probably be multiple target interventions.
Okay, thank you. There's another question from Laura. Hello, Justine. Thank you for the presentation. Is there any specific part of the brain, perhaps, for example, the prefrontal lobe, that is first affected in the beginning of dementia and Alzheimer's, or is it a generalized thing?
So one of the first, there is a certain areas that get affected first and then next other areas. It's not really my area of expertise, but what's very known is that one of the first areas is the temporal, the prefrontal lobe. It's very common, by the way, in vascular dementia that region is affected and can also lead to apathy, the prefrontal part. I think within AD, it's mostly temporal, with hippocampal atrophy, the memory center. So yes, there's definitely regions that are affected in a certain order, more or less. It's not always, of course, the same, but the temporal region is very common in AD as a first region.
Thank you. We've got an additional question from Catalina. How is mixed dementia currently diagnosed in clinical practice? And are there any promising advancements in diagnostic tools or criteria for more accurate and timely identification?
So how it's diagnosed in clinical practice is then, for example, they look at like, okay, so in CSF you're positive for amyloid and tau, and also you have a positive tau amyloid PET scan. So then they say, okay, if you have amyloid PET scan, you're on the AD pathological pathway, and if you then also have an MRI scan showing advanced vascular damage, and maybe presence of several cardiovascular risk factors, then they put it down as mixed dementia in the status. But so that's how they put it then in the chart. It's mixed dementia, but it's very tough, of course, also for a clinician or a diagnostic person to say like, okay, it's mixed dementia, but you cannot know like what part of the clinical decline is attributable to the amyloid-beta pathology and what part of the clinical decline is. You can speculate about it, but you'll never know, because particularly the vascular damage is quite variable in either having less or more advanced clinical symptoms. And the new diagnostic tools, well, the plasma ID biomarkers, which I mentioned, are very promising in a less invasive tool to also quantify AD pathology in first line even, or in less advanced memory clinics that do not have a PET scan, or memory clinics that do not do lumbar punctures. So they can be very helpful for timely identification. Yes.
Okay, thank you. We've got a few more questions. This one is from Owana. Hello, Justine, and thank you for your great presentation. Is the program of preventing and reverse cognitive decline of Dale Bredesen applied in your clinic? If yes, does it have measurable results?
No, Dale Bredesen is not part of our clinic as far as I know. We are participating in the worldwide finger trial. And the finger trial is a Finnish trial that's now rolled out all over the world. It's huge. And the finger trial showed that a multi-modal lifestyle intervention targeting diet, monitoring of cardiovascular risk factors, I think more exercise. So they implemented lifestyle interventions, and they showed that those intervention group compared to the controls showed less cognitive decline. So the finger, that's also nice to look into for you, the worldwide finger consortium, they're testing it all over the world in all kinds of different settings to see how lifestyle interventions are impacting cognitive function, vascular cognitive decline.
Okay, thank you. We still got 3 questions and we're done with questions. So the first one is, what are cognitive benefits in the case of the US new drug on already diagnosed patients with AD?
What are the cognitive benefits? Yeah, let me see. So these drugs, the aducanumab and the lecanemab, are done in early AD. And the question is, what are the cognitive benefits? Yeah, I don't know by heart, but for example, on the ADRS, the dementia rating, Alzheimer dementia rating scale, then they show that, for example, both groups decline over time, but the treatment group with lecanemab, for example, shows relatively less decline over time. The same is true for donanemab. So that's early stage in the newest drug. It was also early AD disease, but they selected patients that were not only amyloid-beta positive, but also criterion was to be tau positive. So still early stage clinical wise, but they had both pathologies and they also showed less decline. I can't say an effect estimates by heart, but so less decline on rating skills for cognition over time.
Okay, thank you. The second question is, are there any limitations of relying only on biomarkers for AD dementia diagnosis? If yes, what are some of the limitations?
That's a good question. Yeah, it has many pros because it's more objectifiable in a way, and everybody talks about the same thing and researches the same disease. Yeah, I can imagine that the downside is that if there's no in several low how do you call it, low middle income countries, LMIC, low middle income countries, not every hospital or every setting has the opportunity to assess these biomarkers. And then then you can still, of course, on your clinical syndrome, be very likely have AD. But if you do not have the opportunity to measure the biomarkers, then you do not meet the criteria. So I think, it can be maybe too restrictive in a sense that you do need to have the opportunity to measure it, or else you can't classify people who are very likely have AD as a clinical syndrome, but you can't pinpoint it down to the biomarkers. So I think with implementation in different settings and in various hospitals, various socioeconomical statuses, it may have its downside, and you need to be a bit more open-minded, I think. Yeah.
Okay, thank you very much, Justine. This was it for the questions. We really enjoyed your presence. It was very insightful to hear your presentation.
Thank you.
Thank you very much.
Thank you so much. All right.